Hi everyone, I'm really excited to give this talk, a little bit unusual talk for me, on allergic contact dermatitis and irritant contact dermatitis in facial eczema. And I'm coming from New York City. These are my disclosures, nothing related to this talk. And as we know, atopic dermatitis is a complex disease that has both immune but also barrier abnormalities. And when we think about atopic dermatitis, it has abnormalities in type 2 cytokines such as IL-4, IL-13, IL-5, IL-31, but also IL-22, the type 22 cytokine. And also it has some variable Th1 and Th17 abnormalities. And of course, it has also a vast barrier abnormalities. Now, irritant and allergic contact dermatitis are highly associated with atopic dermatitis, including facial rashes, but also rashes in other areas, such as hands and other parts of the body, for which we definitely need to do patch testing to understand if it's an irritant reaction or if it is a true allergic reaction. What about facial eczema? Facial eczema has a variable pathogenesis because it really depends on the primary condition we have at hand, and of course the primary allergen we have. And why is that? Because irritant contact dermatitis is a Th1 and Th17 immune profile, whereas allergic contact dermatitis is skewed towards a Th1, Th17 profile if we're talking about metals such as nickel or cobalt, but it has a Th2, Th22 profile if we are talking about rubbers and fragrance. And this is why patients with atopic dermatitis have more fragrance allergy, because atopic dermatitis is a Th2 and Th22 driven disease. And we know that atopic dermatitis, while it has a Th2, Th22 profile, it does have some differences depending on the phenotype. For example, children differ from others. So we need to keep all of this in mind. So ideally, treatment should be directed towards primary abnormalities. And of course, we need to remember that we need to identify either the irritant or the allergen so that we really can treat it very well. What are some of the relevant allergens for facial and for eyelid dermatitis? Preservatives in cosmetics, fragrances, rubbers, medications, nail polish, artificial nails, plant allergens, and shampoos. And I'll show you just some of them because I don't have so much time. This lady was exposed to fragrance that was actually in her husband's aftershave, and look at her face. She had rash on her face due to exposure, not her own exposure, her husband's aftershave. This guy was applying a facial aftershave as well, and he is positive to Opmos Absolute. And this woman also was applying facial creams that had fragrance. Many facial creams and also sunscreens will have fragrances, and she's positive in patch test of fragrance mix. Nail polish. We see that as a major problem in patients that have eyelid dermatitis, because we all tend to touch our eyelids, and this lady was allergic to silamide, that is a main ingredient in nail polish. Artificial nails or acrylates, again, major issue when we are dealing with the eyelids and also the neck. As you see here, multiple allergies. Rubber allergy. We need to remember applicators of cosmetics, and this is what this lady had. She had a rubber allergy, and here is what she was using. And also eyelash curlers, they tend to have rubber. They also have metals, and this is what this lady was using. Importantly, medications. We can have allergies to different medications such as bacitracin, gentamicin. We need to also remember that they have cross reactions. And here is a lady that was using bacitracin in her nose daily, and another lady that was using polysporin around her eye. Steroid allergy. While this is rare, we can be allergic to steroids that we are prescribing, and we need to keep that in mind. such as this person that was allergic to tixocortol, and then another person allergic to budesonide. And we need to remember that because we need to know which class of steroids we need to prescribe. And preservatives. We have also preservatives in steroids, such as a propylene glycol or quaternium 15, as we can see here. And look at this lady and what she has. And again, look at what we have here, facial rashes. And many facial lotions, including emollients, have preservatives. So you really need to think about that when patients are not improving and even getting worse when you prescribe for them either a steroid or they're using an emollient, and sometimes it's an emollient that they were using a long time. Another person with facial rash, and look at that, Aquaphor, because it has a lanolin. And wool wax alcohol or lanolin is an ingredient in many moisturizers. So we need to think about that because sometimes the moisturizer that the patient was using actually is not good for them. And look at the reactions. Now, hydrocortisone creams and many other steroid creams also have preservatives. Here you see quaternium 15. So we need to really be thinking about preservatives, not only in cosmetics, but also in moisturizers and in creams that we are prescribing. And Caton CG, another one that is in multiple cosmetics, emollients, and medications. And here we see Eucerin for the hands, face, and body. And other steroids, Ultravate cream, and you see Caton CG, that's methyl chloroisothiazolinone that is there. And also we need to think about propylene glycol when we see that somebody is not improving with topical steroids, because many topical steroids have propylene glycol, you need to consider that. And other preservatives such as methyl dibromoglutaronitrile, it's in cosmetics such as mascaras, but it is also in many emollients such as Lubriderm. So we need to think about these preservatives. Also, we need to think about those natural or botanical derivatives, because many patients are like, oh, doctor, I'm using something natural. So something natural may have many ingredients that actually the patients are allergic to. And you need to think about that, and that market is not regulated. And in fact, from my experience, we found many patients allergic to ingredients that they don't even know about or cannot even identify which ones they are. Now, studies done in botanical preparations found multiple of these botanical preparations to be those that patients become allergic to. I want to point out few, but you see the whole list here. Tea tree oil, right? Many patients think, oh, this is great to use tea tree oil, but it's a major allergen. And also some fragrances such as balsam of Peru or lavender, chamomile, and many others. And we need to remember also botanical preparations have also additives such as propylene glycol and others. So very important to keep that in mind when we are talking to patients and they just tell us, oh, doctor, I'm using something natural. I actually tell them, I really prefer that you use something that we exactly know the ingredients and is regulated rather than something that we do not know what it is. So thank you so much for your attention.